All right. Welcome to Dental Webinar Series today. Today, we are privileged to have Dr. Cynthia Udeh with us. She's going to be presenting on a topic that is very interesting, and she will give us a whole lot of details. Before we get started, I just want to do a little bit of an introduction. Dr. Cynthia Udeh obtained a dental degree from the Texas A&M College of Dentistry in Dallas, Texas, and she now went further to pursue prosthodontics via a residency program at the University of Texas Health Science Center in San Antonio, where she got a certificate in prosthodontics and also a Master of Science in Dental Sciences. She's also a fellowship, pursuing a fellowship in maxillofacial prosthodontics in the legendary Mayo Clinic. I know, once she's done with that, the sky, I guess, will be a starting point. Pretty impressive. Dr. Cynthia Udeh, we are so thrilled to have you on Dental Webinar Series this Sunday afternoon.
Thank you. Thank you. I'm going to start sharing my screen if that's okay.
Yes.
Okay, let me get that going. All right, can everyone see my screen?
Yes, I believe. If you can see the screen, just type in the chat. If you can hear properly as well, just type in the chat section and we'll get going. Okay. But I think it's good. Go ahead. Yeah.
So hello, everyone, and welcome. Thank you for being here with me today. Before I get started, I really do want to thank Dr. Uva for the very kind introduction. And I'm also very grateful to be here today because I do really appreciate that many of us are out here trying to share information, and Dr. Uva is doing a very wonderful job of trying to get information out there, and I'm glad I have the chance to be part of that today. So we'll be talking about splinted implant-assisted treatment options for the full arch reconstruction. Okay. So here are some of the learning objectives for today's presentation. At the end of this, I hope y'all will be able to understand the basics for treating the dentulous arch with splinted implants, indications for each treatment options or design, and considerations to help in achieving a prosthesis that has a good long-term prognosis. So a major point of this presentation is to make sure that as clinicians, we realize that the benefits of implant dentistry can only be achieved when the right treatment option is applied to a well-evaluated patient. So we have many ways to treat our patients, and the choice of the treatment needs to match the patient's expectation and the clinical diagnosis that we make. So we should be able to prescribe a prosthesis based on our patient's existing anatomy, so how they present to us and what treatment goals we're trying to get to. So a very important question we need to ask ourselves as clinicians is that how can we match the right treatment option to our patient? We're not trying to match the patient to a prosthesis that we have in mind. So implants are and will continue to be a very valuable treatment modality for us, but it's important to remember that the ultimate goal for our patients when they come to get treatment is not to have implants in their mouths, but to have teeth that they can function with. So for us, this means that our treatment should always be prosthodontically driven. So we need to start with teeth in mind. There's no point of having implants if we cannot support or retain a prosthesis adequately. There are many classifications that we can use for prosthetic options, but one that is frequently used and very common is the MISH classification for specifically implant-assisted prosthetic options. So I'm sure many of us are already familiar with this, but I'm going to just go very briefly for those of us who are not. So here, FP will stand for fixed prosthesis, while RP will stand for removable prosthesis. So our FP1 here refers to prosthesis that replaces the little crown, so it looks like natural teeth. FP2 will stand for prosthesis that replace the crown and a portion of the root, so it might look like long teeth. FP3 will replace crowns and the gingiva and the bones, so it looks like pink and white prosthesis. RP4 is an overdenture prosthesis that is supported completely by implants, and RP5 is an overdenture prosthesis that is supported by both soft tissue and implants. So all these different prostheses will have different restorative space requirements and design requirements, and we'll go over some of that today. So now that we're familiar with that classification of implant supported prosthesis, we can now talk a little bit about the conventional denture. I love dentures. I think they are very important. They're a very important aspect for treatment planning are full arch prosthesis. And usually for many clinicians who are still following the conventional or traditional treatment routes, and we're not using full digital processes and all of that, the denture is still the very first step for treatment planning our patients going through the full arch rehab. So these patients have lost teeth as well as bone, and making a denture allows us to model that restorative space. So we get the teeth in the ideal position. It allows us to fine-tune the aesthetics, and it also helps us to, finalize our patient's phonetics and sets us up for ideal implant planning. So when we look at a complete denture, it's a treatment planning tool. Like I said, it helps us determine what kind of final prosthesis is ideal for our patient. So we can determine if the patient has enough space for the prosthesis we have in mind. We can restore their vertical dimension. We can determine their ridge relationship if they're a class 1 or a class 3. We can determine if they need a flange or not for lip support. And we can determine how much pink or white they will show in full animation. So basically how much of the prosthesis they will show if they smile fully. So here we can see a patient that is restored with a denture. We can get our patient to the ideal position. And once we do that, then implant planning can begin. We can plan for the ideal implant positioning, and a denture will basically guide us to help us make sound surgical decisions. So implants can provide retention, stability, and function, which in turn will help improve the quality of life of our patients, their confidence when they have their prosthesis in their mouths, and just their, how comfortable they are around their friends and families and in social situations. So implant dentistry can also help us provide prostheses that are not as bulky for our patients. So things like less acrylic or extensions that are not as extended, if that makes sense. So for example, would be a palateless maxillary denture, things like that. So now let's talk a little bit about splinted versus non-splinted implant planning. So we know that there are advantages and disadvantages to connecting our implants together to allow them to function as one unit versus allowing the implants to function independently. So the important question we need to ask ourselves is why and where we can effectively apply the advantages that we gain if we choose to splint our implants together. So there are so many ways to splint our implants for full arch treatment. There are countless design options, but as long as there is a good understanding of the mechanics and why the implants are splinted, and you're actually achieving the desired treatment effect, then your design is valid. So there are various factors to consider when we're deciding why to splint our implants for our full arch treatment, and we're going to talk about that. But before we delve into all the details about why we're splinting, the first thing we need to have in mind is just because you can place an implant doesn't mean you should. So just because there is bone available for implant placement doesn't mean an implant has to go there. So there's no reason why we have a patient that has 18 to 20 implants in their mouths, but they still can't have a prosthesis that is predictable or well-fitting. So having individual implants for each teeth or having too many implants in the patient's mouth is not a treatment strategy. You're just placing implants. So the various factors to consider when deciding why to splint implants, one of the biggest reasons on our patient side of things would be cost. So whether they get 4 implants or 6 implants or 8 implants in an arch, these different numbers of implants can actually provide similar or the same level of function for our patients. So we can work on costs with them for that. But as clinicians on our end, there are so many other reasons why we can splint our implants. We can look at things like restorative space, stress distribution, hygiene, being able to retrieve or remove the prosthesis, implant divergence, and if we want to cantilever our prosthesis, treatment time, chair time, and so on. So let's talk about benefits of splinting. So one key benefit is improved force distribution, and that's one of the biggest advantages. So by spreading chewing forces across multiple implants, splinting will help us relieve stress on the individual implants, the surrounding bone, and it's very valuable in cases where our patients have very high bite forces or they have parafunctional habits that we need to control. So splinting can also help enhance stability of our prosthesis. It creates a very rigid foundation, which is very helpful when we're trying to provide support and stability for a patient whose anatomy doesn't provide that for them. So the stability is especially useful when we are also trying to cantilever prosthesis. So this is when the portion of the prosthesis extends beyond your most posterior implant or your most anterior implant. And splinting will help provide the necessary support to manage the forces on this type of prosthesis. And another advantage of splinting is that a splinted prosthesis can help reduce chances of mechanical complications. So things like screw loosening or screw fractures can be reduced. And splinting also helps reduce micro movements when our patients are functioning. So this helps to protect the bone to implant connection and also just helps to, improve overall stability of our prosthesis. So splinter designs can also result in fewer interproximal contacts to manage. This just helps to simplify the process of delivering a prosthesis for our patients. So for some of us who have delivered individual crowns for full arch, we know that you do have to manage multiple contacts, multiple regions of the prosthesis, but having a single prosthesis on splintered implants can help to reduce the risk of things like foot impaction for our patients, plaque buildup in between restorations, and just less areas our patients will have to clean. Splinting can also be very cost effective for both the patients and the lab and also the doctors. So with fewer individual components required, so things like abutments or bars and things like that, the overall expenses and production can be a little lower because we're not trying to get parts for multiple prostheses, but instead just one unit of the prosthesis. So it's also a simpler design. So being a single unit makes the prosthesis a bit less complex to fabricate and manage, and this can help streamline things for the lab and the dentist. And another advantage is that splinting will distribute forces effectively for patients where we cannot place multiple implants. So some patients come in and they don't have enough bone for implant placement. So we can place few implants strategically, and that will provide the same level of function for these patients compared to a patient who still has a lot of bone, and we can place implants wherever we want. So while splinting dental implants has many advantages, like we just talked about, it also comes with certain disadvantages that also need to be carefully considered. So a key challenge when we splint prosthesis is achieving a passive fit, and that's when your prosthesis sits passively on your implants without straining them. So fabrication errors can occur during different points in the production process, impression or verification, things like that. But whenever our prosthesis is not passive, it increases stress on our implants, the surrounding bone, and it can lead to mechanical and biological complications. So we can see things like fractures, bone resorption, screw loosening, and so on. Another drawback is that it makes maintaining oral hygiene a bit more difficult. So the connected design can hinder cleaning and increases the risk of plaque buildup and periimplantitis around our prosthesis if our patients can't keep it clean. If one part of the fixed prosthesis fails, typically, since it's one unit, the entire restoration has to be removed for repair or replacement. And this can add, time to treatment for our patient. It can add costs, and it's also inconvenient for the patient. So when we're deciding to splint implants, we must carefully balance the benefits that we get, like stability and load distribution, with the challenges that we can face in getting the passive fit, hygiene difficulty, and long-term management of these kind of prostheses. So I do want to talk a little bit more about hygiene. So Splinted restorations can make the use of dental floss hard for our patients and just complicates oral hygiene. And when we're fabricating a splinted restoration, the lab technician or the dentist or the prosthodontist, whoever is designing this, should create a well-designed restoration that provides a cleansable, convex, or flat surface that allows easy access for interproximal surfaces. So we do not want a fixed prosthesis that has, let me get my pointer. We don't want a fixed prosthesis that has a concave intaglio surface or a flange. This is going to prevent our patient from being able to effectively clean their prosthesis. So typically for full arch restorations, I always confirm with the patients if they can clean under their prosthesis. I always practice with them and I see them for follow-ups to make sure that they're actually effectively cleaning their prosthesis. So this can be a prosthesis that serves them for a long time. So what are some situations where you would like to splint implants? Some examples would be in cases where we have very short or narrow implants. Typically, we would like to spread the amount of forces amongst all the implants in the arch. We also have situations where implants are tilted or they're not angled ideally for the type of prosthesis we want to provide for our patients. So splinting this can help to correct angulation because the bar can be fabricated in one plane. So the angle of the implant is no longer going to matter. What we're concerned about is the angulation of the bar. And in patients where they also have very high load potential or poor functional habits, splinting is very helpful. In cases where we're aiming for immediate function, so for example, is our all-on-X cases, splinting implants through cross-arch stabilization. So when we're splinting all the implants across the arch on both sides, this will provide a very rigid prosthesis that helps to spread forces and allows our patients to function immediately. And then in cases where we aim to provide support and stability for patients whose anatomy doesn't provide that, splinting is also a great idea. Let's look at treatment options. When we're restoring the edentulous arch with implants, one of the major decisions we have to make as clinicians is if we want this to be restored as a fixed prosthesis or a removable prosthesis. And there are several designs that can be used to restore our patients, but knowing when to use the design we pick is important. So with our overdenture type designs, we can typically obtain our support from implants or the mucosa or both. But in cases where there are enough implants in the correct position with enough AP spread, then we can produce a fixed implant restoration for our patients that is completely implant supported. So I'd like to review some of the literature around this topic. So we have a systematic review here where the objective was to assess the influence of splinted and unsplinted oral implants in the mandibular and maxillary implant-supported overdenture. So they found that there was no difference in the per-implant outcomes between the splinted and unsplinted designs. The use of splinted or unsplinted designs for implants that support an overdenture is not a factor that affects the implant success and survival rate of the peri-implant tissues. So basically, I say whether you have an unsplinted or splinted designs, your implants are still going to help be healthy, and you can, use either design successfully. There are other articles out there with similar findings. Here, this one says that the survival rates of implants and overdentures and the patient's level of satisfaction with their maxillary overdenture supported by implants was not influenced by the overdenture design. And there was no statistical difference detected between the splinted and unsplinted groups. And this meta-analysis here shows that there was no statistical significant difference between the splinted and unsplinted attachment systems in regards to things like marginal bone loss, complications, and implant survival rates. So I completely agree with the literature, but this literature, I think, is only true in cases that are designed strategically. So how can we be strategic about our design so we can have a successful prosthesis? So when we're looking at our implant-supported prosthesis and management of our fully edentulous arch patients, this requires understanding of the amount of vertical and horizontal restorative space that is needed for different types of prosthesis. And whenever we fail to design our prosthesis without considering the space that we need, we'll definitely end up with issues. And this can cause our rehab to fail. It can cause it to have diminished stability, poor aesthetics, and inadequate contours, and our patients will not be satisfied with our prosthesis. So we always want to evaluate the available restorative space, and we always want to determine this before we start treating our patients so that we can ensure that we have space for the design that we have in mind. Also, selecting the retention method and design affects the space that is required. And there are advantages and disadvantages for doing fixed or removable and whatever design we pick. And we'll look at that a little bit. So I won't spend too much time here talking about the locator overdenture because we're here to talk about splinted implant options, but typically this needs the least amount of space when it comes to our removable prosthesis. On average, it needs about 8 to 10 millimeters of space. And these are the components that are included when we're trying to measure the amount of space that we need. So space for our teeth, our acrylic, our denture attachments, and so on. But for our bar overdenture cases, which is our splinted implant option for removable prosthesis, this will typically require a bit more space. So typically we're looking at about 11 to 15 millimeters of space. And this kind of prosthesis typically requires a bit more space because we have a bar, and this bar needs to have adequate thickness for it to have good prognosis. And also in the mandibular arch, sometimes we have to include hygiene space for our patients, also in the maxillary arch as well, so that they can clean underneath their bar. And this typically adds about 1 to 2 millimeters to our restorative space. This is typically a minimum amount of space needed. And the more components we have, or the more bulky our bar is, then we need more space to accommodate all of that. So let's look at some treatment considerations for our implant supported prosthesis. So for the bar overdenture, patients who have fair to poor anatomical presentations, they typically require a bit more stability and support for their prosthesis to be successful. And these are very good candidates for bar overdentures. This option typically offers a more stable and supported prosthesis for these patients to be able to function properly. One consideration for the bar overdenture is that it's typically a delayed function prosthesis. And what that means is that from the time the implants are placed to loading of the prosthesis on the bar, there is typically a good amount of time in between. So we have to consider time for the bar fabrication. We go through like the impression, the verification, we send that to the lab for that to be made before we can finally get the bar back and load our denture on the bar. So there is some time between placement and insertion. And in contrast to the literature that we're seeing today about the locator overdenture, the locator overdenture is now typically considered an immediate function prosthesis because as long as your implants go in well, you can immediately load your locator overdenture. This is not something I typically do, but that's just because of the population of patients I'm treating currently. But people are doing it successfully, and that's something you might want to consider trying in your practice if you don't already do that. So many times the bar overdenture prosthesis may be the more expensive option for our patients comparing to the locator overdenture or the non-implant assisted prosthesis. And this is because there might be more components required. So sometimes we have to place things like abutments before we place our bar. And one other consideration is that in cases where implants are not ideally placed and we're having trouble using the implants individually because of their angulation, the bar overdenture is one of the best ways to angle correct so we can use those implants and just, successfully have a prosthesis made for our patient. This is also in contrast to the locator overdenture, which typically we always want parallel implants for them to be successful. Many times we see patients returning to the clinic for the denture, for the dentist to change out their locator overdenture inserts, and that's because their implants are not parallel and their inserts are wearing a bit faster. So what can we do to maximize the success of our bar overdentures? Well, we want a well-designed bar. So this means that the bar does not compromise our material thickness, and it does not compromise our denture contours as well. So you want to have adequate acrylic thickness around the bar, and this will prevent our prosthesis from fracturing. Many times when people design a bar or, they design a prosthesis that doesn't have enough space, what they do is that they overcompensate by bulking out the acrylic to give it thickness, but this is not something that will be comfortable for the patient. And ideally, when we're trying to obtain more support from our implants, it's important that we are placing them with a good AP spread so that we can gain more support. If we place our implants in one line in the anterior ridge, that's not a design that can produce fully implant-supported prosthesis. So we're also typically, we also need a well-designed superstructure or an internal framework. So this is an example of an internal framework, something that goes into the denture so that we can have a better long-term prognosis. Just because typically there is a bit more or an increased amount of forces applied to an implant-supported prosthesis, an internal framework or a metal superstructure is one way to help minimize fracture of the prosthesis over time. So we're going to look at some splinted design considerations. This information here is something we all learned in dental school. Whenever that was for you 10 years ago, 5 years ago, if you're currently in dental school, but it's something that's important because understanding this is still key to making a very successful prosthesis. So here's a nice summary of factors that affect support, stability, and retention of our complete denture. And I won't spend too much time going over each one because it's something that, we can easily have access to ourselves and read up on if we've forgotten about them. But it's very important for us to be able to evaluate the anatomical structures of our patients. And we have to understand that, we have to understand why the structures provide support. So we look at things like the buccal shelves and the mandibular arch. We look at factors that affect retention like saliva or achieving a peripheral seal for denture retention. And we have to know that if these things are compromised, how can the design of our prosthesis help to replace these things in our patients? So let's talk about support a little bit more because understanding this is key to designing a prosthesis that has good mechanics. So we have 3 levels of support when it comes to our removable prosthesis. We have tissue supported, we have implant assisted, and we have implant supported. So your removable prosthesis can fall into any of these categories. It just depends on your design and attachment choice. So supported means support comes fully from your implants. Assisted means it comes from both the tissue and the implants. The use of implants in a completely or partially edentulous arch does not typically dictate whether if that prosthesis is tissue or implant supported. What actually determines if it's tissue or implant supported is that we have to figure out if there's a rotational line that exists in our prosthesis. We have to figure out if when the patient functions, does the tissue compress and give support to that prosthesis. So let's look at what it means to have a rotational line or a fulcrum line. So this is a line that passes through a point around which your prosthesis can rotate under function. And this line is typically at right angles to the path of movement. So if we look at this image right here, we have a bar over denture design. When the patient bites down in the back, the prosthesis will kind of rotate a little bit around this bar in the anterior ridge. And this green line right here is our fulcrum line. And basically anything in front or behind this fulcrum line will move in opposite directions. So let's look at rotation around an axis. So now that we understand a fulcrum line, we need to understand what a bar unit is versus a bar joint. So a bar joint, I kind of remember that with my, a joint moves around. So a bar joint refers to a bar attachment system that allows some movement around the bar. So it allows your prosthesis to move around your bar, and it allows for movement like vertical translation, so up and down movement or rotation. On the other hand, we have a bar unit, and this is an attachment system of a bar that is rigid and does not allow for rotation. So if you look at the images right here, this bar unit right here gives no space around the bar. So it has parallel walls, there's no space around this. And if you try to imagine this trying to rotate, there is no space around this for any rotation. So it's a bar unit and it does not allow for much movement. On the other hand here, we see this bar design where there is space underneath here for the prosthesis to rotate. So if you imagine, if this tries to rotate, it can freely rotate around this circular portion of the bar, and that will be considered a bar joint system. So the rigidity or resiliency of our prosthesis comes from the bar design and our attachment choice. So another concept to keep in mind is something called tissue displacement or tissue resiliency, and it refers to the amount of to which our oral tissues can compress under pressure or under function when our patient is eating, talking, biting down. This means that if there is any support coming from the tissue, we should expect a bit of movement because tissue is typically compressible to some degree. So once we know that our prosthesis will have a certain range of motion because it has some resiliency coming from the tissue, we have to allow for that range of motion. So basically, we don't want a situation where we're pressing down on the prosthesis, the tissue is being compressed, but our attachment does not allow for that movement. If that happens, we're stressing our prosthesis, we're stressing our bar, we're stressing our implants. So this can also cause our patients to be uncomfortable as well because the whole system is just stressed and sometimes they feel that tension that things don't feel right in there. So a bar joint, which is the one that moves, that allows for movements, they're typically used with attachments that will rotate with the prosthesis. And this rotation is important because when we apply force, we don't want our attachment to disengage. So our attachment system should allow for functional adaptation during processes like chewing or speaking or biting down. And it helps to direct forces away from our implants and our bars, okay? And if we look at the image right here, we have a short anterior header bar in this case. And then if we're looking at this design here, back here is tissue supported clearly. So it wants a bar joint as our attachment system. So it's to allow for some rotation around this fulcrum line right here. And this design is tissue supported. We have implants, but most of the support is coming from the tissue. And because this is allowing the freedom of rotation with our attachment choice, this is not going to disengage when the patient bites down. If you can imagine, if this had a rigid attachment, our patient bites down here, everything up here is just going to go up and then that's going to disengage. So in summary, you have to ask yourself a couple of questions when you're trying to determine if your prosthesis is tissue supported or implant supported. And one of the first question is there a rotational line? Okay. Is there rotation around that axis? Is there tissue displacement during function? And is there any movement under function? If your answer is yes to any of these, then you do have some tissue support and you have to use an attachment that allows for some resiliency. So in summary, if your prosthesis has tissue support, then we want to find that fulcrum line, and that tells us basically how and where we can place attachments and what type of attachments we should use. So things that can influence tissue support versus implant support is number of implants. So the more implants you have, the more likely you can get your prosthesis to be fully implant supported. Fully implant supported prostheses have no fulcrum line and no rotation because they are fully rigid. The spread of your implants, so the more spread out your implants are, the more support you can get from those implants. Number of bar elements, number of retentive attachments, and these things will determine if your prosthesis is tissue or implant supported. So let's look at two examples here. In the image right here, we can see our classic 2-implant locator over denture. This is a tissue-supported prosthesis. It's also implant retained. And on the other hand here, we have a prosthesis that is retained with a milled bar, and this has locator attachments on top of it. This prosthesis design is fully implant supported and also implant retained. We're going to look at some designs. Some of the common designs we see for our bar over denture prosthesis. We have designs that come with resilient attachments. These are attachments that will allow for some movement, so like our bar joints. We also have non-resilient attachment systems that do not allow for much movement. So those will be our bar units. And then we have prosthesis that can be retained through friction on the bar. We also have prosthesis that can be retained through friction on the abutments. And then we also have prosthesis that lock in place because the bar has a superstructure that has a locking attachment. And we'll kind of look at some of these in the coming slides. So we have our classic bar designs that are very simple and very functional. And as long as you know how to use them, they are very successful. We don't need to like make a very complex design because these things have been around for a very long time and they've been very successful. We have the round bar, we have the Doda bar, and we have the Hader bar. Let's talk a little bit about the round bar. So the round bar is a low profile bar. As the name suggests, it has a circular cross section. And the round shape will allow for flexibility because if you can imagine it's round, things can kind of rotate around it. So it allows for rotational movement. It's low profile, so it saves us a lot of space. And it can also be cast to match the contours of the tissue because it can be well customized. And it allows for hinge movement around an axis. So the round bar is commonly used in combination with Ackerman clips. And these are examples of Ackerman clips up here. These are available in different designs to help us accommodate for various clinical situations. So in cases where we don't have a lot of space or our space is limited, this first design right here is what we'll typically use. They're a bit more compact. Compared to this second design here, which is what we can use when we have enough space, it has extensions that go upwards. It allows for very good retention in our acrylic, but it also requires a bit more vertical space. So that is something you can pick depending on your clinical situation. Ackerman clips can also be used with a spacer. So if you look here, this is the bar, this is the housing, and this is the spacer right in between. And we typically use this spacer because we want to introduce vertical resiliency. So we want to allow the prosthesis to be able to go up and down when the patient bites into the denture or applies forces on their denture. So this allows the prosthesis to have controlled vertical movement and helps to absorb some of the functional forces and reduce stress on our implants and the bar. So typically when the patient is not biting down, their prosthesis is tissue supported, it's sitting on their tissue, but when they bite down, this will go down and sit right on the bar and stop the denture from being overseated. So you get some support from the bar when the patient is biting down. So it's very important for these clips to be picked up in the lab on your cast and not in your patient's mouth because a lot of times it's hard to control where this is rotating in the mouth. So it's good for us to see it in the lab and pick it up in the same direction because we don't want this picked up in opposing or non-parallel directions. So we're going to look at the Doda bar. The Doda bar is kind of an oval-shaped or like an egg-shaped bar that also has a spacer inserted between the bar right here and its sleeve or its housing. And this will permit the sleeves to have vertical movement, just like the round bar. So if the patient bites down, the attachment can move down and sit right on the bar. And it also allows for rotational movement because there is space down here for this to rotate around the bar. So it's considered a resilient attachment or like a bar joint system. And also similar to the round bar, during rest position, the denture will sit on the tissues or the alveolar ridges and is considered completely tissue supported. But during function, the Doda bar will allow for vertical translation, right? And you can also allow for frontal or sagittal rotation as well. This bar does have different designs, and this can vary by size and resiliency. So just like the round bar, in some situations, we might have more space or less space. The Doda bar can come in a macro or a micro design. And then we also have two cross-section designs. We have the oval shape, which is this design right here. And we also have the U shape, which kind of looks like an upside down U or an arch. And it's very important to know the difference between these two types of bars, okay? So the oval shape of the Doda bar, it has like an egg-shaped cross-section. It allows for rotation because of the shape. So there's space down here for things to rotate around the top part of the bar. And it typically comes with resilient clips. So we use this when we have some tissue compression or some tissue support, so we can allow for rotation. But on the other hand, the U-shaped loader bar, it has a U-shaped cross-section, it has parallel walls. There's no space for anything to rotate around this bar. So this will be considered a bar unit, and it's typically used when we want a very rigid prosthesis that has no rotation. Typically, we can use it when we have fully implant-supported bar over denture designs. So here we're going to look at the Hader bar, and the Hader bar is very commonly used these days. I see that a lot passing when patients come to the clinic. And this design, it has a round superior portion, and then it has an apron going down towards the tissue. And these bars are really great also if you know how to use them correctly. Most things that work really well if you use them correctly. So the Hader clips are designed to rotate around the height of contour or the round portion of the bar up here. And it's ideal to pick this up in the lab as well because they are designed to rotate. And in the patient's mouth, you can't control if it's rotating a different way. And you definitely want to pick it up in the right orientation. So always pick it up in the bar, in the lab if possible. And when it comes to processing the components of the Hader system, it also comes with the spacer, but the spacer does something a little different here. So if we bring our attention to this photo right here, we're going to look at these two sides of the prosthesis. So on the left side of this picture, this shows kind of like a tunnel created using the processing spacer of the Hader bar. And basically the flange of this clip has room to flex around the bar. So it's kind of curved in. So if you imagine once it's trying to sit on this bar, it has to kind of flex around it and come back in to engage it and actually clip onto the bar. So it needs some space around it for it to flex out when it's sitting on the bar and then come back in to clip on it. But on this other side, we can see that there's a problem here because this wasn't processed with the spacer. The acrylic is abutting right against the attachment or the clip. And what happens is that the clip is now locked in because of the acrylic, and the flanges of the clip are pressed inwards, basically making an insertion of this clip impossible. So because when you're trying to push this over the bar and this can't flex out because there's no space, what happens is that our clip is going to press in and it's going to stop the patient from being able to use this properly, or this is going to keep bending and over time it's going to break and our patient is going to come back in and they're like, oh, this is not working. Like you promised it was going to be retentive, but it's not. And you have to keep changing the clip all the time because the patient keeps having problems. So that's one way to, you have to pay attention to something like this to use the Hader bar successfully. Let's see. So let's look at some of the designs for our resilient bars. In the first picture, this is our classic design for a bar denture if we're using 2 implants. This type of prosthesis will be considered as tissue supported and implant assisted because we are getting some support from the bar when our patient is functioning, but typically it's mostly tissue supported. And as we discussed earlier, if your prosthesis is tissue supported, we're going to require that rotational or hinging motion to allow dispersal of forces, and we want to prevent disengagement of our attachment. So we want some freedom of movement for our prosthesis. So leaving the bar in the anterior portion here, we're going to have a fulcrum line in the anterior. So if our patient bites down on the back teeth, we're going to have some rotation here and our attachment accommodates for that rotation. So this will be a very successful prosthesis. In the second design here, we do have a little bit of a problem. So this design has a bar that is cantilevered posteriorly, which basically moves our fulcrum line backwards to, like, let's say the premolar region, which is not very ideal. So this denture, we want to rotate around there for like the fulcrum line. And like we discussed before, things on either side of the fulcrum line will move in opposite directions. So as you can imagine, if force is applied back here, everything here is going to go up, and that can cause our prosthesis to disengage. And even if it doesn't disengage, something has to kind of give somewhere. So our denture can even snap in half because of the forces that have been applied here. So a lot of times you do want to consider where the forces are and where your fulcrum line is and your rotation is going to be. A more ideal design, if we want to cantilever our bars posteriorly, would be this. And this is typically going to be a completely implant-supported design, which means that a fulcrum line doesn't technically exist here. So because of our attachment choice, and because the bar is extending all the way back towards the molar region, if the patient bites down, there's no rotation around this, so everything goes down in one direction. And typically, since it's fixed, we're going to be avoiding any mechanical complications. What we can do here for this design is that we can go ahead and take this to the lab and just cut off this part that's extending back here. And we can keep our fulcrum line anteriorly right here. So that would be a very similar design to this design here. So the other type of bar design is a milled or freeform milled bar. And this is a custom-made bar attachment system. So it offers a very durable and strong fit. It's designed to match the patient's ridge and implants, and the bar provides very excellent retention. It gives us flexibility because we can customize this with different attachments. So we can put any type of attachment we want up here. It could be a ball attachment, it could be a locator attachment. And we can also design this so it's rigid or resilient. So we can design this for implant-supported prosthesis or tissue-supported prosthesis, or I guess implant-assisted prosthesis. So it's very ideal for complex cases because we can definitely customize it to fit our situation, and it can provide very good stability and retention for our patients. But one disadvantage of this bar design is that it's definitely bulkier than our classic round bar or Hader bar. So we definitely need a bit more restorative space if we're trying to use something like this. And we're going to look at different designs for milled bars. So we have the two implant classic milled bar here. And one great characteristic of this milled bar is that it has a locator attachment here. Here it has the ball attachment. And these are very great designs because even though we have a milled bar, the attachment system will allow for resiliency. So it's a very great option if we have a tissue-supported prosthesis, because since the locator and the ball attachment allows rotation in any direction, if the patient bites down, this can kind of pivot a little bit, and we can still have a very successful prosthesis. When we're planning for a milled bar for a tissue-supported prosthesis, we definitely want to use a hinge or a universal resilient attachment. And we'll talk about that a little bit more in the next slide. So a hinge versus a universal resilient attachment. So a hinge resilient attachment will only allow for hinging rotation, and it can't really resist other forces because it's designed for only hinging. An example will be our Hader clip. So our Hader clip is designed to just allow for up and down or back and forth motion. But on the other hand, we have a universal resilient attachment, which would be like our ball attachment or our locator attachment. And this allows for all kinds of movement in any direction. So there's a very high amount of relief to like our implants and our bar, because that allows for tipping in any direction depending on where your forces are applied. So if you look at the images on here on the left, locators can physically pivot in any direction. So let's say we have 3 implants. The patient bites down back here. There's definitely like a fulcrum line between these that go in the same direction. So this can, pivot successfully without straining the system. But on the other hand, here on the right, we have a hinge resilient attachment system. And here we have 2 unaligned Hader clips, and their fulcrum lines are in completely different directions. This will not allow us to hinge or pivot when our patient bites down. And this would definitely strain the system and can cause some mechanical failure somewhere. So the first bar design here is good, but this is not a great design. One of the other bars we can consider for our patients is the Paris bar. It's kind of a hybrid design combining the convenience we get when we want to have a removable prosthesis, but it also has a polished finish that kind of looks like a Montreal bar, and I'll explain what that is later. And the gingival surface to the side near your patient's tissue is very highly polished, so it makes cleaning very easy. And also, just like the milled bar, it kind of accommodates any attachment system you want to place on top here. Here's an example of one with locators. And this is very customizable for our patients. So This design also has something called a skirt extension. So it has like a horizontal skirt extension that will help provide support for our denture. So when our patient bites down, the denture will stop and sit on this and prevents it from going any further down or moving. So this is typically used for very rigid, completely implant supported designs. So we'll talk about something called the fixed detachable prosthesis. So the fixed detachable bar design is a rigid prosthesis, typically always fully implant supported, and is secured in place with attachments that can be removed by the patient. So fully implant supported, no flexing, no rotation or rigidity, is very stable and is very durable. And although our patient will have a fixed experience with this design, it also allows our patient to remove it whenever they want to for hygiene purposes, typically. So for example, here we have a Reebok bar with an MK1 attachment, which is this attachment right here. So these kinds of prostheses are typically made with the mesostructure, which is our bar down here, and it has a superstructure, which that attachment is placed on. And you can see this locking system. And what happens is that whenever the patient puts their denture down on the bar, this locks into the bar. So it's fixed and it's rigid. But the patient is also provided with a key where they can unlock their prosthesis and take it out to clean it as needed. Very similarly, from Preet, we have something called the universal plunger lock system. And this locks the prosthesis into the bar as well. And it also has a key that the patient can take out as remove their prosthesis as needed. So we're going to move on to our completely fixed implant prosthesis, and we're going to talk about ways to maximize success for our fixed implant prosthesis. So in order to have a successful treatment for our fixed restorative options, we have to consider many factors. So things we can look at will be restorative space, which we kind of already talked about a little bit, but we definitely want to have enough space to accommodate all the parts of our fixed prosthesis. We want to be able to evaluate our patient for their lip line to ensure that the prosthesis and tissue junction is not visible, depending on what design we're picking. We also want to make sure that we have adequate AP spread of our implants because we're getting all our support from our implants. So we want them to be spread out appropriately so that our prosthesis can be well supported. And it's also important to consider the level of patient compliance. So if they can actually take care of this prosthesis, we also want to consider things like their parafunctional habits or their bite force. Some patients, this is not a good idea for them to have a fixed prosthesis. And one more thing we want to consider is biologic cost. And this means what are we taking away from our patient to put a prosthesis like this in? We need to remember that prostheses like our barber denture and our fixed prosthesis, they typically require a bit more biologic cost to the patient, especially for patients who have not lost all their bones. So because we need a bit more space for these prostheses, typically during surgery before we place our implants, we're chopping off all the bone to create that space. And we definitely want to have a good talk with our patients about what this means because, implants ideally will last forever, but that's always or typically not the case. And especially for our younger patients, we want to make them aware that, bone never comes back. And if at this point, it might be better for them to do a prosthesis that requires a bit, less space. And then later down in life, if they are having issues, at that time, you can take out, filling implants or whatever and actually take out bone, and they'll still have something for us to work with. So let's talk a little bit about design considerations. So for our fixed denture prosthesis, typically about 50 millimeters of space is a good guiding rule for how much space we need for our FP3 style prosthesis. And that's because we need thickness of the metal. We also need some hygiene space, typically for our mandibular arch. And on the other hand, when we're looking at our zirconia prosthesis, a lot of times you can get away with a little less thickness. So maybe like a 13, 12 millimeter will be enough for a zirconia prosthesis. So let's discuss the term hybrid. A lot of times we many people just call the fixed denture prosthesis a hybrid, which is, it's fine as long as we know what we're talking about. But hybrid is technically like a slang term and is a non-specific terminology that is used to describe a dental prosthesis that is composed of different materials. So in this case, we call it a hybrid denture because the classic design was a fixed complete denture that was made of metal and acrylic. But now we have so many, material choices. And it could be metal acrylic, it could be metal composite, it could be metal ceramics, and we'll talk a little bit more about that. So whenever we have patients that require maximum retention, or who have difficulty using the regular conventional denture because their anatomy doesn't work for that, they don't have enough bone support or ridge height, things like that, that will be an indication for a fixed complete denture. There are also many patients who are they have very poor anatomical expectations and they can't really use their complete denture, and they really do know what they want from a prosthesis. They want something fixed. They want something that feels close to their teeth. So this would be an indication for patients that want a very high degree of function. So always, we do want to consider the amount of restorative space, and I'm gonna keep bringing this up because I think it's very important. Like I mentioned earlier, we are trying to match the prosthesis to our patient, and the only way to do this is to very thoroughly and preemptively treatment plan our patients and evaluate them. So for example, for a patient who ended up with a prosthesis that looks like this, who came to us for a smile that actually looks like this, the only way to achieve this smile is through proper surgical and tissue planning. So typically the patient will have to go through implant placement in the ideal position, through tissue shaping in provisionals before we can get something that looks like that. So in a case where the patient was not evaluated properly for things like gingival display, like this patient has a very high lip line, they weren't evaluated properly. This is an FP3 design that was used in the restorative space for an FP1 case. So things like that, we do want to make sure that we're seeing the full picture before we place implants and try to restore our patients. So for many clinicians, the solution in this case would be to like chop off all the bone to get the proper space. But like I said before, it's just a good idea to spend a little bit more time talking to our patients about what that biologic cost is. And so we can definitely make the right choice for them and think about things that might happen in the future as well. So for many of our patients, this is a treatment of choice because they also want immediate function. So they want to be able to get their implants today and function on that today. And that's good because for cases like this, if everything goes well, we can definitely immediately load and patients can immediately function. But in cases where the patient is also opposing natural teeth and they also want a less bulky prosthesis, a fixed denture is also a very good treatment option for those patients. Because it's less likely to get compromised by forces produced from the opposing arch, because our natural teeth has very high forces versus like a complete denture or something like that. So many times we also want a very durable, long-lasting material choice. And whatever that choice is for you, the fixed prosthesis can be made with a variety of materials. So whatever material that offers us that long-term durability, we can typically get that for a fixed prosthesis. I do want to talk a little bit about level of dexterity, because for me, this is one thing I cannot seem to have like a one style fits all for all patients, because there are very many reasons why our patients might have dexterity issues. So for patients who have these issues, a fixed or a removable prosthesis, they're both difficult for them to actually use properly. And for our removable prosthesis, the patient has to be able to remove it and reinsert it in their mouths. And for a fixed prosthesis, they have to be able to clean underneath it properly. So the solution for this kind of patients may be to let them trial out both kinds of prosthesis. So let's say they come to you and their desire is to get a fixed prosthesis. You can start with that. And if they're having issues actually keeping that clean, like you're seeing them frequently for follow-ups and like everything looks really bad, it might be an indication for you to try to transition them to something removable. And maybe we can, Ask a family member for help to help keep them, help them keep their prosthesis clean. Hygiene is also always a very big issue for patients like these, and especially our older patients. We do want to sit down with them and take some time to kind of help them find things that work for their hygiene. So the other thing is that we can use some tools to help them if they're having dexterity issues. So material choice. The choice of the material for our prosthesis can depend on several factors. So one thing you always want to consider is your opposing dentition, like what is in the opposing arch. This will influence things like wear of your material. It's going to influence compatibility with the opposing arch material. So you definitely want to pick a material that either matches your opposing dentition or might be a little weaker than your opposing dentition, especially if you have natural teeth. Other things to consider will be finances. So we all know that there's different levels of materials. So things like zirconia or lithium disilicates might not fit our patient's budget because those may be a bit more expensive versus something like acrylic. The other thing is aesthetics. So for patients who have very high aesthetic demands, so things like zirconia and lithium disilicate might be very good to use in the anterior, but posteriorly, we know we're more concerned about function and durability, so that might not be a good thing to use in the posterior, especially for patients who have very high load potential. Something else that can influence our material choice is our lab. So we know that not all labs are created equal, so our lab choice will definitely impact the outcome of our prosthesis. Other things that we want to think about is complications and maintenance in the future. So for patients that don't have great compliance, never come for their follow-ups, they don't clean their prosthesis, something that is really strong and very highly polished or smooth, kind of like, let's say, zirconia versus acrylic, zirconia might be a better choice for them. Their expectations and function, those are also things that we want to consider. Some patients have very unrealistic goals for what they can afford, so we definitely want to match, educate them on what they are paying for. And of course, our high load potential on our patients with poor functional habits, things like zirconia and metal might be a great choice than acrylic for them. So there are many materials we can choose. Examples would be our conventionally processed metal acrylic fixed prosthesis. We have a milled metal acrylic. We have metal ceramics. We have metal composites. We have monolithic zirconia, and we have metal zirconia. So there are many options that we can pick. We just have to know which situation fits the material best. Most commonly, the metal that we're using for our fixed complete denture currently is titanium and our cast noble metals. But many times, this is something you can discuss with your lab. I've seen some cases where people are using PEEK, but I did not know enough about PEEK and the long-term studies to show how this is functioning in the mouth. So this is not something I use, but if you do use it, there are definitely indications for it, but I personally don't use PEEK for any fixed prosthesis. So here we can see some common fixed prosthesis complications that we can see in the clinic. So for our metal acrylic prosthesis, we see things like chipping of the acrylic, we can see wear, we can see screw fracture, screw loosening, and fracture of the prosthesis, teeth falling out, and things like that. For our zirconia prosthesis, some of the complications we can see are fracture of our veneering ceramic if we are veneering like lithium disilicate on the zirconia. We can see wear of the opposing arch. We can see discementation of the tie bases. We can also see some screw fractures or screw loosening. One thing we also want to consider for our fixed prosthesis is material thickness. Honestly, for any prosthesis, our material thickness is very important. Adequate thickness of our material is very important to prevent mechanical complications, to prevent things like fracture, especially in zirconia. So we need very good amounts of material thickness around our tie bases for us to, because that'll be our weakest point and it's likely to fracture there. We also want to make sure that we have very good amounts of material around our connectors as well. One thing we want to consider is passive fit of our fixed prosthesis. It's very important that we can get our prosthesis as passive as possible. When our prosthesis is not passive, we can have many mechanical and biological complications that we definitely don't want to be dealing with. And there are many ways to check for the passive fit of our prosthesis. So the first thing you always want to do when you get your case back from the lab is to confirm fit on your cast. So you want to trust, you've trusted that you've made a good impression and your cast is correct. So whatever you get, you want to make sure it fits on your cast before we take it to the patient's mouth. And there is no one technique that works alone to confirm passivity. So it's a very good idea to find a few that work for you and combine all of them to make sure that your prosthesis is passive. So for me, there are 4 techniques that I typically use all the time. I always use radiographs, but one thing you want to consider about radiographs is that depending on the angulation you take, you might be missing something. The other one I always use is the alternate finger pressure. Basically, what that one is that you put pressure on one end of your prosthesis and see if it lifts on the other side. In the mouth, you see like air bubbles, or you see that your prosthesis is not seated on your abutment. We also have the one screw test, which is a test where you put a screw down in one end of your prosthesis. You screw that all the way down and see if the other abutments or the other tight bases are lifted off your prosthesis. And then the other test I use frequently is the screw resistance test. So whenever you're tightening your screw down, you can start from the middle and work your way backwards. You want to make sure that once your screw is tightened, you do not have more than half a turn before it's torqued. So that's one way to know if your prosthesis is not passive, that, there's resistance, or you're hearing some creaking sounds, or like there's more than a full turn for you to get that screw to stop turning. Here there are many articles that, we do want to consider AP spread, and there are many articles that will talk about AP spread and cantilevers. But my philosophy with that is that you want to avoid them at all costs if you can. A lot of times, we have to cantilever prosthesis just because we don't have enough implants, or our patients doesn't present with enough bone for us to give them all the teeth that we want to give them. But definitely you don't want to cantilever more than 1 or 2 teeth. And whenever you are cantilevering a prosthesis, the cantilever ratio to your AP spread should always be less than 1. So let's look at the bar designs for our fixed prosthesis. So these are some of the common bar designs we see for our fixed prosthesis, and I'll kind of show you images and describe them a little bit. So this is the Montreal bar I kind of mentioned before, and gingival surface of this bar is in metal. It's very highly polished, so it's very good for hygiene for our patients, because very highly polished prosthesis doesn't have as much plaque buildup and calculus attachments to the highly polished surface. So it's also a really good design choice because you can contour this to soft tissue. Retention of this prosthesis it's obtained from the design of the bar. So there are several ways you can do it, but in this case that I worked with a lab on, the retention is getting through holes in the bar. So what happens is that when you process your acrylic to the bar, the acrylic is going to pass through the holes, and that's how your material is being retained on your bar. This case was designed for a maxillary arch, and you can see that the bar conforms to the shape of the tissue, because typically we don't want an air gap in the maxillary prosthesis. So we want it to touch the tissue and compress a little bit, but we also want our patients to be able to still pass floss underneath to be able to clean. In contrast here, this is a case that was done on the mandibular arch, and it's done a little differently. So the bar design is still the same. We have the retention holes. But one thing that we do want to definitely give our patients in the mandibular arch is hygiene space, just to make things easier for them to clean. A lot of times, because like our saliva pools on the mandibular arch, especially in the anterior portion, patients have a lot of plaque buildup and calculus buildup there. So it just helps to keep things a little easier for our patients to manage. As far as the Montreal bar, different materials can be processed to it or cemented on it. We can also mill the zirconia teeth design, and then we can cement that to the bar as well. So this is another variation of the Montreal bar. It has a lingual metal surface. So The retention in this case is achieved because we have some retention pins on the buccal surface of the bar. The metal will extend posteriorly on the lingual surface to provide a smooth and highly polished finish for our patients. And this is just to help them with hygiene, like we talked about. Cleaning that lingual portion can be a little hard for some patients, so it's just something to help them keep their prosthesis a little cleaner. Here we have the wrap around bar design, and here, the material wraps around the bar completely, and that's kind of how the retention is obtained for the material for this type of design. And you can see there are no holes passing through here, so retention is gained because the material is completely wrapped around the bar. And typically, this is my preferred design choice for the maxillary arch, especially for patients who are getting acrylic, because sometimes we get, when patients are healing after surgery, it might take a little longer for them, and over time you might see that there is some gap between the prosthesis and the tissue. So this is very a convenient way or design for us to kind of add acrylic later if the patient needs that, because acrylic will bind to acrylic, and it's very convenient for us to fix issues that way. This is another variation of the wraparound bar or the Montreal bar. It's called the pin bar, and in this case, retention is also provided for the teeth. And pins, whenever you're designing this digitally, you're going to recognize the area where the teeth are, and then you're going to design pins that will go into the teeth. And this is an example of a case I did, but here I chose a wraparound design with pins. So the material is going to wrap around the bar for retention, but we also have extra retention for the teeth as well. Here, this bar is called the thimble or the mallow bridge design. And this is kind of where the framework will simulate crown preps, and another material can be cemented or veneered onto this framework. And this design produces very aesthetic results. We can use ceramics or zirconia as a veneering material, and this can be very aesthetic. And many people like this design because sometimes you can use single crowns on the preps, and this is typically your weakest link in the design. So let's say your patient bites down on something hard one day and they break a crown. That can be easily replaced with another crown instead of having to remake the entire prosthesis, but it's one of the more expensive prosthetic options. Here in this case, the case I did with monolithic zirconia. So we can also make our prosthesis monolithic. So this is not considered hybrid because it's technically made of one material. It can be used with or without tie bases. So you can have the zirconia straight to your implant abutments, or you can have a tie base that sits on your implant abutments. Typically, I always use a tie base, but one complication that we have with this is that sometimes these tie bases will de-cement if they are not tall enough or retentive enough. Excuse me, sorry. The entire prosthesis has to be remade if you have a complication or an issue. So you have to take this off and remake it. A lot of times, since it's designed digitally, you always have the STL file of your prosthesis, so you can always make it again. But before you do that, you always want to figure out why that prosthesis had a mechanical issue, because if you put the same prosthesis back in, you're likely to have the same complications. So you want to definitely figure out why that prosthesis broke or you're having issues, and you want to fix that before you deliver another prosthesis. Here we have the monolithic design, but this will be for an FP1 or an FP2 case. This is a situation where you have to pay attention to your contours, because a lot of times your provisional is going to match your final prosthesis. In this FP1 prosthesis, the contours will shape the gingiva, and a lot of times you can deliver like a monolithic one-piece prosthesis as well that will match the topography of your gingival tissues. And that is the end of my presentation. Thank you so much. And if you guys have any questions, this would be the time to ask.
All right, thank you so much. That was a really good, very detailed Guys, we need to go back and check out. You need to read. I mean, so many examples. I've listened to many presentations. I've never seen this amount of detail in terms of bars and different types. I learned so many new things today. Believe me, believe me. Anyway, I do have I think there are two questions here from Dr. I know you had clarified one of the questions during your presentation. It was asking about the difference between implant assisted and implant supported. So I remember there's a slide where you did talk about that.
Yes, I can talk about it a little bit more, but a lot of times when we are thinking about terminology, there are different levels of pickiness. Some people are like, you have to use the right terminology, some people are not. And just depending on where we are in the world, the terminology is not uniform. So I feel like the most important thing is knowing what that means for you and your patient. So implant assisted is that you're getting some support from implants, but as well as tissue. And implant supported means that you are getting your support mainly from implants. So it's just kind of like yeah,
Okay, cool.
what that means, yes.
There's also a question here about the use of the role of the conometric concept. Um,
Podometric concept.
yes, where in terms of other than in terms of the type of retention. Um, I
I'm
think
not familiar with the codometric. Are you talking about the conus type prosthesis, like
I
the
get. I mean, somewhat where it is not held down by yes.
oh, like maybe frictional retention?
Yes, yes, yes.
Let's see.
Frictional.
Yeah, so I think that works very similarly. It's still considered a fixed restoration. So your bar design is going to be like any other bar for like your fixed or removal prosthesis. You want that definitely passive. And obviously you have to design the superstructure, the teeth that goes over that, like very intimately close to the bar so that you can get that friction. It works
Mhm.
the same way as any other prosthesis, but obviously you and your lab have to design that very nicely so the patient can actually put it on and take it off predictably.
Okay, good, good, good. Yes. I mean, that's about all the questions we have here. If you have any other questions, please let us know. I wanted to just talk about something before you go on. I know you did residency and you are in fellowship right now. What's the path? What is it like? Obviously, you schooled, your first degree was in the United States, right?
Yes.
Okay,
Yes.
so yeah, so I even amongst that, very few people who school here go into pros, because people just want to go and start working in
Yeah.
AGD and they move on. So why? Yeah, what's the process? What was residency like for 3 years? I know many people have been asking me this. A lady, a dentist from Cameroon, she wants to do pros, and she's been asking so many questions. Can you just give us a little thing before you leave, just about pros and what it takes?
Okay, so PROS is one of the more demanding residencies, I would say, just because you do have to have a very, very detailed understanding of dentistry for you to do PROS. A lot of times we're making prostheses and we're replacing missing parts. So there is a lot of didactic and hands-on work required for you to do a PROS residency. So a lot of times people are saying, oh, like prosthodontists are the people who know everything about dentistry because you do have to know about surgical planning and implants and teeth and everything. So there's a lot of information because whenever you have complex cases that involves multiple specialties, usually pros is the bus driver. You're the one like telling people like, I want this here, I want that here. This is what I need to like successfully treat the patient. So there's a lot of information and dedication that you need for your pros residency, but I think it's very worth it. Like depending on the level you want to go to understand dentistry, like pros will definitely get you there. It's very detailed, but it's 3 years is a long time, but it passes by really quickly and you gain a lot from that experience. So I definitely recommend it if you are interested in pros.
Okay. One more question here. It says, how do you determine vertical dimension of a patient with a TMJ problem if you planned a fixed prosthesis? Fixed, yeah.
So whenever patients come in with any issues with their joints, you do want to resolve that before you start doing any fixed work or any permanent alterations to their dentition. So many times I would say we get minimal training on TMJ disease in dental school. Many times you do want to refer your patients to a specialist before you start treating them. So definitely your practice, you always want to start by evaluating their joints if they have any pain or any issues or their bite is off. A lot of times you want to resolve that joint, just release any tension and see what that looks like. And whenever you determine there's an issue, you always want to resolve that first because a lot of times TMJ disease is transient and their bites can change over time depending on if there is inflammation or disease in their joints. So you don't want to do anything permanent before you start. And as far as determining vertical dimension, I wouldn't say it has anything to directly do with your TMJ. A lot of times we're evaluating vertical dimension from external features like their face, interocclusal distance at rest and things like that. So, but definitely before you start any permanent alterations for your patients, you want to resolve joint disease first. Oh, Dr. Ovo, you're muted, so I can't hear you.
Yeah. How long is residency in process?
Residency is 3 years, and I'm doing an extra year of fellowship for maxillofacial prosthodontics. So for me, it's 4 years, I
4
guess.
years. Okay, nice. The last one here is how can we correct a mistakenly done implant level impression taken without a digital scanner?
How
I
can
don't know.
we...
Yeah, go ahead.
Sir, can you ask that question again? Let me make
You
sure
say
I'm...
how can you correct a mistakenly done implant level impression? Maybe it was inaccurate, I guess.
Oh, like, okay. The solution is to take it again. You just,
Yeah,
if you
I thought.
have any issues with your impression, the impression is really important because anything from that point on, your prosthesis, everything that your lab does is going to be based on your impression. So if you make your impression, it's always good practice to have a verification appointment. So you want to verify that your impression is correct before you send that to the lab, because sending a bad impression to the lab is a very expensive mistake. And a lot of times when labs discover that the mistake is not from their end, you're going to have to pay for the remake of that prosthesis. So you definitely
Yeah.
want to always have a verification appointment to make sure that your implant